Good afternoon, everyone. I'm Kate Kernan, and I'm an assistant professor of critical care medicine here at the Children's Hospital of Pittsburgh. And I'm going to talk today about immunogenetic liability in severe pediatric sepsis. Please feel free as we're going along to enter any questions you might have into the chat. I'll answer them all when we get to the end of the talk. And I wanted to offer a big thanks today for the Center for Rare Disease Therapy and this talk's organizers for giving me this opportunity to speak. I have no conflicts of interest. As an outline for today's talk, first we'll briefly discuss the epidemiology of severe pediatric sepsis. Next, we'll define genetic liability and its relationship to complex diseases like sepsis. Next, we'll understand immunogenetic liability in severe pediatric sepsis specifically, and finally, examine the role of complement-related variants and phenotypes of severe pediatric sepsis. Severe pediatric sepsis accounts for nearly 1 in every 10 PICU admissions. It has a mortality between 14 and 25%, which is 5 to 8 times greater than the mortality rate from all other PICU indications combined. In total, it's estimated to contribute to more than 1/3 of PICU deaths and cost the US up to $7.3 billion annually. And while on this global scale, we can acknowledge the personal and financial costs of severe sepsis, for any one individual, we're still left with a lot of questions. Perhaps now more than ever, we're all aware that pathogens are ubiquitous, but for those who require intensive care, we're often left wondering why some people get sicker than others and seemingly have increased liability for severe disease. This concept has been formalized in the liability threshold model, that for a given trait, populations exist along a distribution of risk or liability, made up of both genetic and environmental factors. In the model, disease occurs when a certain liability threshold is crossed, and an individual can be expected to develop a multifactorial disorder. This liability can be largely environmental, as in individuals with a significant past history of smoking, who are at 30 times the risk of developing lung cancer compared to non-smokers, or largely genetic, as in women with the BRCA1 or 2 mutations who have 30 times the risk of developing breast cancer in their lifetimes than women without the genetic variants identified. Additionally, this liability threshold can result from some combination of environmental and genetic risk factors, as in this man, Ryan Clark. He is now retired, but for a time was a free safety for the Pittsburgh Steelers. Ryan Clark has sickle cell trait, a genetic variant that's typically considered to be well below the threshold of disease, and occurs in 1 in every 13 African-American babies born in the United States. However, in 2007, while playing in a game at Mile High Stadium, Ryan developed severe left-sided abdominal pain, prompting his immediate departure from the game, his emergency medical evaluation, where he was ultimately found to have an acute splenic infarction and abdominal hemorrhage that resulted in emergency surgery for splenectomy and a month-long illness where he ultimately loses 30 pounds. With this, he becomes a high-profile example of complex disease, where an underlying genetic vulnerability in the context of significant environmental stress becomes an important causal factor in a complex disease. And so when we apply this model to think about why children with infections get sick, while environmental characteristics of the pathogen and the care environment undoubtedly play a role, we can begin to ask, can immunogenetic variation be leveraged to understand a portion of the why kids with severe sepsis get sick? And so when we started to think about what genes would likely impact this severe sepsis liability, we chose to leverage what was known about inborn errors of immunity. These are genetic loci known to have significant impact on immunologic function. Over the past decade, increased use of next-generation sequencing techniques, largely for diagnostic purposes in children with suspected immunodeficiencies, has led to an exponential growth in our understanding of the genetic basis of inborn errors of immunity. In fact, the International Union of Immunologic Societies, or IUIS, meets biannually to update the compendium of known inborn errors of immunity with monogenic causes, which, when we completed this analysis, numbered at around 430 specific monogenic conditions and currently spans nearly 500 specific genes as causes of primary immunodeficiency. And while early genetic studies on the risk for sepsis tended to use GWAS or SNP approaches that focused on the bottom right of this figure, that tried to find single nucleotide polymorphisms with relatively small effect sizes in large number of cases of individuals with severe sepsis. Current studies using the whole exome or genome sequencing approach build on what is known about the genetic architecture of primary immunodeficiencies and try to evaluate the hypothesis that multiple variants that are rare and have relatively high penetrance and effect are the major genetic contributors to susceptibility to sepsis and other complex diseases. So when we began testing this hypothesis, we started small with a case series of 6 adults from the PROCESS multi-center trial of protocolized early goal-directed therapy or resuscitation strategies for septic shock. From this 1,300 patient randomized controlled clinical trial, we selected 6 adults with features of macrophage activation syndrome, including hepatobiliary dysfunction and DIC, and extremely elevated ferritin. This subset was relatively young compared to the age of the overall cohort, with a mean age of 56 years, and ultimately 5 of 6 suffered 30-day mortality. These adults underwent whole exome sequencing and filtering to identify rare pathogenic and likely pathogenic and immunogenetic conditions, which ultimately identified 11 variants previously reported as causal for the primary immunodeficiencies of familial hemophagocytic lymphohistiocytosis, atypical hemolytic uremic syndrome, familial Mediterranean fever, and cryopyrin-associated periodic fever syndromes. In children, while the literature on this topic is sparse, there has been a historical effort to understand the relationship between immunodeficiency and atypical presentations of sepsis, as in this report on the incidence of immunodeficiency in children with recurrent invasive pneumococcal infections, such as bacteremia or meningitis, often occurring after the administration of pneumococcal vaccination. In this case series of 15 cases of unexplained recurrent invasive pneumococcal disease in children from birth to 15 years of age in Denmark, underwent screening for functional defects in TLR signaling, complement and B cell function, as well as quantitative deficiencies in T cell, B cell, NK cell numbers, and total quantitative immunoglobulin levels. And using this approach, 10 of the 11 cases had identifiable defects, including 6 cases of complement deficiency, 3 cases of specific antibody deficiency, and 1 case of a TLR signaling defect. While many of these cases were presumed to be germline encoded, no sequencing was performed during this study. Also, in this report by Ascari et al., this examined a young cohort of children with no past medical history who presented for the first time with Pseudomonas bacteremia. In the group, 8 of 11 died, all within 48 hours of presenting to hospital. 5 of the 11 were found to have viral co-infection at the time of their critical illness, with viruses including HHV6, RSV, human metapneumovirus, varicella, and parainfluenza. These 11 children underwent whole exome sequencing to identify inborn errors of immunity-related variants, and ultimately, 6 of 11 were found to have potentially pathogenic immunologically active variants. And in follow-up to the Ascari study, this same Swiss research group utilized a larger cohort to examine the prevalence of primary immunodeficiency-associated variants in previously healthy children with all-cause bacteremia. The study included 176 children from birth to 17 years of age with 2 SIRS criteria, which is defined as the presence of an abnormal temperature, an abnormal respiratory rate, abnormal heart rate, and abnormal white blood cell count, and culture-proven bacteremia. Among these children, 38% ultimately required ICU care, and more than half had no evidence of organ dysfunction. In screening, they used a subset of 240 genes from the IUIS classification of inborn errors of immunity that were expected to increase liability for bacterial infection, and a rare minor allele frequency filter. Using this approach, they found that 20% of variants had variants of 20% of individuals had variants of unknown significance in IEI-related genes, and 2% of participants had pathogenic variants. However, they were not able to identify a relationship to phenotype, including organ dysfunction, mortality, CRP values, leukopenia, pathogen type, or sites of additional infection. Our work asks a similar question, but focuses specifically on children with severe pediatric sepsis and aims to understand the ways in which individual genetic variation influences predisposition and disease course during critical illness. As a first step in this endeavor, I sought to quantify the prevalence of inborn error-related variants previously reported as causal for primary immunodeficiencies in children sampled from the Phenome's prospective observational cohort of severe pediatric sepsis. This study occurred in the Collaborative Pediatric Critical Care Research Network and included 330 children between 44 weeks and 18 years of age who were admitted to one of 9 U.S. pediatric intensive care units with sepsis-induced organ failure, the presence of a central venous or arterial line catheter, and whose families provided consent for whole exome sequencing. Following sequencing and quality control, we filtered individual variants to identify immunologically relevant candidates. First, we limited our investigation to genes in the 2019 International Union of Immunologic Societies classification of monogenic causes of inborn errors of immunity. In the second step, we required that the variants be rare, with a minor allele frequency of less than 5% in population-based screening projects. Third, candidates were required to change amino acid structure. In the fourth step, remaining variants were evaluated in a human genetic disease database, where we retained only those variants classified as pathogenic or potentially pathogenic, based on prior literature reports of the specific variant in human disease. Finally, we required that all variants were found in an inheritance pattern consistent with its disease, requiring 2 mutations for autosomal recessive conditions or 1 for autosomal dominant or X-linked recessive in males. When I discuss this filter, I like to pause here and emphasize that while this research filter shares many steps similar to what might be seen in a clinical diagnostic sequencing workflow, it's intentionally more permissive and aims to capture a larger set of genetic variants that could plausibly contribute to the overall genetic liability to severe infection, rather than require the specificity of a diagnostic panel for monogenic disorders. The main functional evidence for the disease relevance of the variants sampled here are based upon QIAGEN's Human Genetic Mutation Database. This is a literature-based annotation tool that reviews the peer-reviewed literature for prior reports of the variant as causal in a case of human disease, and then grades the likelihood of association based upon its total occurrence in the literature. And to better illustrate their approach and the approach adopted in our work, I like to read a few quotes from the user's manual. HGMD includes the first example of all mutations causing or associated with human inherited disease. Users should not assume that just because a mutation is labeled pathogenic, that the mutation is disease-causing in all individuals. It has always been the HGMD policy to enter a variant into the database, even when its pathological relevance may be questionable, rather than run the risk of inadvertently excluding a variant that may be directly relevant to disease. Using this approach, on the right, the figure shows the prevalence of these genetic findings. Of the 330 children that completed sequencing, 200, or 60% of study participants, had at least one variant that had been previously reported as causal in a case of inborn error of immunity. This included 96 children with more than one variant and 89 previously healthy children. Further, when comparing the clinical characteristics of children with and without candidate inborn errors of immunity, we see that while the groups are well matched in terms of their age, sex, and medical history, including previously healthy status and history of malignancy, we did observe that African American children had 2.4 times the odds of having an immunologic variant identified. And additionally, we noted that children who had inborn errors of immunity had 4 times the odds of requiring ECMO, while other organ support therapies did not differ significantly between groups. When examining the specific candidates variants we identified, it became clear that the genetic landscape of pediatric sepsis is highly heterogeneous. The figure to the right shows every pathogenic or potentially pathogenic variant identified in the cohort that was found in a disease-consistent inheritance pattern. And moving from inner to outer ring shows the immunologic process, the specific gene locus, and finally the exact variant identified. And while there are 133 individual variants shown in the figure, affecting all 9 IUIS immunologic process classification groups, we see that in total, in blue, complement variants were common, occurring in 92 individuals, or 28% of the total cohort. Other commonly encountered variant groups included those previously identified in autoinflammatory illness, combined immunodeficiencies with associated syndromic features, phagocytic defects, disorders of immune dysregulation, disorders of innate immunity, defects of bone marrow failure, deficiencies of antibody production, and combined cellular T and B cell abnormalities. Due to the association of variant status and ancestry, we also separately characterized the genetic variants specific to African American children. Here, complement variants, again shown in blue, became an even larger proportion of the findings, affecting 54% of African American children on study versus 28% of the complete cohort, a proportion that differs significantly. We also sought statistical evidence of variant overrepresentation among children with severe sepsis by comparing observed variant frequency in the phenomes cohort to large general population databases and across ancestral backgrounds. First, we compared the frequency of alleles in the phenomes cohort to the NOMAD general population database. Here we found that atypical hemolytic uremic syndrome associated variants C3 1407 G to C, 443 G to A, and CFHR3 424 C to T, as well as the type 1 interferon viral response associated gene ERF3 829 G to A, that's been previously associated with recurrent herpes encephalitis, was more commonly encountered in our data set than in the general population. In the second column, we see that some of these variants may be in the second column, we see that some of the overrepresentation may be related to ancestry differences in the study cohort, and that they were significantly more common in African American children than in non-African American children in phenomes. This is exemplified by the variants C3 1407 G to C, CFHR3 424 C to T, CFHR5 434 G to A, and TNF-RSF1A 224 C to T. However, in the third column, we see that not all of the observed variant overrepresentation is attributable to ancestry differences, and that the complement variants C3 443 G to A and CFH 2850 G to T were more commonly identified in African American children in the phenomes cohort than in participants of African ancestry in the NOMAD database. Following variant characterization and statistical frequency comparison, we next examine the relationship between infection type and inborn error of immunity-related status. Here, we looked only at culture and viral testing in the 48 hours prior to or following the development of severe sepsis and organ failure, after reviewing speciation data and removing likely contaminants by site. Subsequently, we found that in comparison to children without identified variants, children with IEI were noted to have 2.8 times the odds of developing a positive blood culture, 8.2 times the odds of a positive urine culture, as well as a decreased odds of developing culture-negative sepsis. Similarly, those children with inborn errors of immunity identified had evidence of increased inflammation, with 2 times the odds of developing hyperferritinemia, 1.7 times the odds of having a CRP greater than 10, 1.8 times the odds of having thrombocytopenia, and 1.7 times the odds of having lymphopenia. We also explored how the incidence of these characteristics differed between variants according to their International Union of Immunologic Societies functional classification, in comparison to children with no variants. The plot to the right shows the log odds ratio, or the magnitude of difference between the group of interest compared to children with no identified variants for a particular microbiologic or inflammatory feature on the x-axis, among children with any variant identified, those with multiple variants identified in each of the 9 IUIS classes, including complement disorders, autoinflammatory conditions, combined syndromic features, defects of innate immunity, phagocytic defects, diseases of immune dysregulation, antibody deficiencies, and combined B and T cell defects. With this approach, we were able to see that the observed traits associated with an IEI variant class differed according to their functional grouping. For example, we see that those children with immune dysregulation-related variants, which include familial hemophagocytic lymphohistiocytosis and its group of related disorders, had the highest odds of demonstrating hyperferritinemia, one of the diagnostic conditions for familial HLH. Additionally, those with complement-related variants had characteristics consistent with microangiopathy, including increased odds of hyperferritinemia, thrombocytopenia, and elevated CRP, an acute phase reactant that's known to interact directly with the alternative complement pathway. Certainly, this approach has study-specific limitations. The first of which is that on a variant-by-variant basis, these genetic findings cannot be equated with an immunodeficiency. This is a literature-based approach without functional validation and inherently relies on the quality of the published research available. We also lack specific disease diagnostic testing for the identified variants, as this was done as a retrospective study. And we acknowledge that many of the identified genetic findings would be expected to have variable penetrance and not be expressed by all carriers. Additionally, while this data was not shown, there was relatively poor DNA extraction and high rates of failed sequencing among children who developed lymphopenia, which was commonly seen in children with active malignancy. Both of these groups represent key pediatric sepsis subpopulations with high levels of risk for mortality. So in the first three portions of my talk, I hope I've convinced you that the genetic liability for severe pediatric sepsis is common and identifiable as inborn error of immunity-related variants. And that even in small cohorts, it's possible to demonstrate statistical evidence of overrepresentation of these variants in comparison to large population databases. And while some of these differences may be ancestry dependent, others persist even when compared to ancestry matched populations. We also observed that the IEI variants observed correlate with infection type and inflammatory characteristics, as well as care needs, including use of ECMO. And finally, that the incidence of these inflammatory and infectious features differed according to the IUIS functional classification of the type of identified genetic immunodeficiency. One of the most striking findings among our initial effort was the frequency of complement variation observed in our sepsis patients, in addition to its overrepresentation among African American children. It also provided us with an opportunity that, due to its prevalence of about 1/4 of study participants, we had a reasonably sized subgroup with power for further analysis of phenotypic effect. The thrombotic microangiopathies are a heterogeneous group of clinical syndromes defined by the presence of hemolytic anemia and thrombocytopenia that, due to a shared final pathology of endothelial damage to blood vessels, leads to activation of clotting cascade and clot formations that manifest with characteristic organ failure patterns. They're known to have a strong heritable component, particularly the two most common heritable TMAs, thrombotic, thrombocytopenic purpura, or TTP, and atypical hemolytic uremic syndrome. TTP is an autosomal recessive disorder characterized by biallelic mutations in Adams TS13 that decrease this enzyme's ability to cleave von Willebrand's factor, leading to circulating ultra-long von Willebrand factor multiples with increased ability to aggregate platelets and cause thrombotic events. In TTP, CNS dysfunction occurs in approximately 70% of affected individuals, with renal injury being the second most common site of organ involvement. Outside of this Mendelian disorder, additional studies have shown that genetic variation in Adams TS13 contributes to complex disease risk and associates with risk of stroke in children and adults, as well as the occurrence of cardiorenal events in type 2 diabetes. The second heritable thrombotic microangiopathy is atypical hemolytic uremic syndrome. This is another heritable disorder that demonstrates the liability threshold model. In healthy individuals, alternative complement is an innate immune pathway that is activated always to a small degree to help clear damaged cells in normal processes of turnover. It's dynamically upregulated during infection to promote opsonization, chemotaxis, and cell lysis. However, in those with alternative complement genetic risk and atypical hemolytic uremic syndrome, loss of function mutations in pathway regulators, including CFH and CD46, or gain of function mutations in pathway activators, such as C3, the principal pathway convertase, promote complement hyperactivation, leading to endothelial injury, vessel swelling, platelet adhesion, and occlusive thrombosis. However, it's important to note that atypical HUS mutations are not fully penetrant and not expressed by all carriers harboring them. But in those that do go on to develop disease, environmental factors, including key activating complement conditions like infection, drug exposure, or pregnancy, lead to the clinical manifestations of microangiopathic hemolytic anemia, thrombocytopenia, and organ dysfunction, with renal disease being ubiquitous, but CNS involvement occurring in up to 20 to 30% of individuals. So with this background, we return to our data set to determine if thrombotic microangiopathy variants would be related to phenotypic evidence of microangiopathy in pediatric patients with severe sepsis, specifically highlighting key features of the diseases, including hemolytic anemia, thrombocytopenia, acute kidney injury, CNS dysfunction, and ADAMTS-TS13 activity. For this, we redefined our candidate gene list for our research question, limiting our study to the intersection of the two most commonly used clinical genetic TMA panels from Machion Diagnostics and the University of Iowa. Similar to our previous effort, we then required that the variants be rare, that they change amino acid structure, and be classified in HGMD as pathogenic or potentially pathogenic based on literature reported cases of thrombotic microangiopathy, including atypical HUS, TTP, or TMA in the setting of drug exposure or the HELP syndrome. With this protocol and our 330 sequence patients, we identified 240 children that had any rare variants identified in a candidate TMA gene, and 130 children that had variants classified as pathogenic or potentially pathogenic that had been previously reported in a case of thrombotic microangiopathy. We also examined how children with and without these TMA variants differed in terms of their laboratory data. Here, we can see that there were non-significant differences in trends toward decreased hemoglobin and platelet values, as well as increased ferritin in children with TMA-related variants, as well as significant increases in maximum CRP and decreases in ADAMTS-TS13 level. As ADAMTS-TS13 is one of the genes included in our candidate list, and a well-known genetic cause of endothelial injury, we wanted to examine if ADAMTS-TS13 activity differences were exclusively driven by the presence of these genetic variants. Here, on the y-axis, you can see the ADAMTS-TS13 activity according to gene locus of the variants identified on the y, beginning with children with no identified variants in severe sepsis, shown in gray. The first blue bar to the right demonstrates that children with ADAMTS-TS13 variants had statistically significant decreases in the gene's activity. And in the second blue bar, we additionally identified that children with pathogenic or potentially pathogenic variants in CFH, the most common genetic alteration found in atypical hemolytic uremic syndrome, also demonstrated statistically significant reductions in ADAMTS-TS13 activity. Additionally, when we compare the clinical characteristics of children with and without TMA-related variants, we again saw that those with TMA variants were more likely to be African American and conversely less likely to be Caucasian. They were also less likely to be previously healthy and were more likely to receive a packed red blood cell transfusion. And while there were no statistically significant differences in the unadjusted organ failure patterns observed in the group, there was a trend towards increased incidence in the development of CNS dysfunction, or a Glasgow coma score of less than 12 in the absence of sedatives in the group of children with TMA-related variants. There was no such signal observed in the incidence of renal dysfunction. As typically, clinical TMAs are diagnosed by a constellation of symptoms, we next looked at the TMA-related features both alone and in combination. Here you see the observed incidence of anemia, defined as a hemoglobin less than the cohort median of age or transfusion requirement, thrombocytopenia, defined as a platelet count less than the cohort median of 115, and the incidence of renal and CNS dysfunction. The column of Venn diagrams to the left shows the counts of children with TMA variants with a given characteristic, and on the right shows those without. The odds ratios for these comparisons are shown in the figure on the right. And using this approach, we demonstrated that children with TMA-related variants had 1.8 times the odds of having a hemoglobin less than 8 or requiring a red blood cell transfusion, and 1.6 times the odds of having a platelet count less than 115. Further, when combined, those with TMA variants had 1.8 times the odds of having combined microangiopathic phenotypes, including thrombocytopenia and anemia. And finally, when combining these laboratory features of microangiopathy with their associated organ failure patterns, we saw that those with TMA-related variants had 3.3 times the odds of having microangiopathy and CNS dysfunction, similar to the most common clinical presentation of TTP. Again, there was no corresponding increase in the frequency of microangiopathy combined with renal disease. Lastly, we wanted to assess whether this association between TMA genotype and CNS dysfunction with laboratory evidence of microangiopathy would persist after accounting for severity of illness and race using a multivariate logistic regression model. Initially, we included age, sex, PRISM score, which is the most common overall severity of illness score used in pediatric sepsis, the first 4 principal components of genetic ancestry, previously healthy status, and the presence of a TMA-related genotype in our full model, based on univariate association testing with a p less than or equal to 0.1. We then used forwards and backwards selection procedures to specify a final model of statistically significant predictors on the right. Here, we were able to show that even after adjustment for genetic ancestry and severity of illness, the TMA genotype remained a statistically significant predictor of the TTP-like phenotype of microangiopathy and CNS dysfunction. So to summarize our investigations on the impact of TMA-related variants on severe sepsis, I've shown you that physiologic and laboratory parameters also associate with TMA genotype, and that Adams TS13 activity percent levels differ by gene locus affected, and that the combined phenotype of anemia, thrombocytopenia, and CNS dysfunction is predicted by the TMA genotype, even after adjustment for ancestry, previously healthy status, and severity of illness. And of course, this only scratches the surface of the questions we're asking about the genetic liability of severe pediatric sepsis. Here I've listed some of our feature directions, the first of which is to have a better understanding of the presence of these immunogenetic variations, and not just sepsis, but other critical illness phenotypes. We also have a focus on quantifying the impact of individual rare variants, but due to the rarity of single mutation events, it requires larger collaborative multi-center efforts. We also plan to return to the lymphopenic septic population. These children suffer a disproportionate representation of morbidity or mortality for severe pediatric sepsis. which will require future enrollment with alternative sampling procedures. We also aim to understand the long-term outcomes of these IEI-related variants and are returning to a follow-up study of 80 children who participated in the phenomes cohort who were enrolled at the Children's Hospital of Pittsburgh, hoping to examine rates of admission, antibiotic usage, frequency of positive blood cultures, and viral testing in this limited cohort. And of course, none of this work would be possible without the help of a large group of collaborators and mentors. So I wanted to say thanks especially to my mentorship group, includes Joe Carcillo, John Kellum, both of the Department of Critical Care Medicine, Jerry Bockley from Clinical Genetics, as well as H.J. Park, Scott Canna, and Dan Notterman. A very special thank you to Lena Gonzalez, without whom this work really wouldn't have been possible, as well as our funding from NICHD and IGMS, the Children's Neuroscience Institute, and UPMC's Institute for Precision Medicine. With that, I'd be happy to take any questions. All right, thanks to everyone for joining in. I hope you have a nice afternoon.